As we pick up the second part of our integument lecture, we're going to start where we left off from part one, which is dealing and discussing the accessory structures of the skin. The first accessory structure we're going to look at is hair. Remember that hair is present on most surfaces except the palms, the anterior surfaces of your fingers, and the soles of your feet. It is composed of dead, keratinized epidermal cells, and we see that genetics plays a pivotal role in determining thickness and distribution of the hair. We have several parts of the hair. These include the shaft. This is what we see above the skin surface. The follicle, which is below the level of the skin. A root that penetrates into the dermis. An epithelial root sheath, and a dermal root sheath. So putting it to diagram, we can see the hair shaft. This is again what we can see that's above and out into the free air. The hair root. We've already discussed in our previous lecture the importance of the erector pili muscle. Here's an eccrine sweat gland. You can follow that to a pore on the outside of our body. Blood vessels, an apocrine sweat gland. Now notice that we have two sweat glands, apocrine and eccrine. Eccrine glands are going to occur over most of your body and open directly onto the surface of your skin. Apocrine sweat glands are a little bit different. They develop in areas abundant in hair follicles, like your scalp, your armpits, and your groin. That brings us to our bulb, so the bulbous portion of our hair root plexus. Before in our previous lecture we talked about blowing on your hair, being able to feel that is because of that plexus, and our sebaceous gland that is oiling this root. We're not going to go too crazy with the internal anatomy or the sectional anatomy of hair, but we're going to quickly outline what it entails because we do see some commonalities as we move through anatomy and physiology through semester 1 and semester 2, specifically our general region. So the hair root has two general regions, a medulla and a cortex. The medulla is the innermost region and the cortex is going to be the outermost region. That brings us to the cuticle of the hair. Our hair follicle has an internal root sheath and an external root sheath. This makes up the epithelial root sheath. Then we have a dermal root sheath followed by and formation of our bulb. So entering into the bulb, we see our blood vessels that's going to nourish this hair. Melanocyte here for pigmentation. Hair matrix followed by again the medulla innermost, cortex outermost. So this is the transverse section of a hair root. Now, the translation from our actual slide to this program didn't really come through properly, and it shifted the arrows to the side a little more in the picture. So the arrows do not line up with the appropriate label. So I'm going to label it for you. Again, in the center, we have the medulla. So if you draw a line here to the medulla, the cortex on the outside of that. So we could draw that here. From there, we go to that purple lining, which is the cuticle. So the cuticle should be here. So cuticle. And then surrounding the cuticle is our epithelial root sheath. We have our internal root sheath with our external root sheath. Okay, and then that gives us this outermost layer, which is our dermal root sheath. Perfect. Skin glands. The skin contains 4 types of glands. The first being sebaceous oil gland is connected to our hair follicles. Our eccrine sweat glands that we said are distributed pretty much all over the body and are the most numerous. Our apocrine sweat glands located mainly in hairy skin, and we said on our scalp, under our arm, axillary, and in our groin, inguinally. And then these weird modified sweat glands called ceruminous glands. And these are what are responsible for essentially making earwax. So it's located in the ear canal and makes our earwax. Table 5.3 summarizes all of our skin glands based on feature, where it's distributed, the type of gland, sebaceous oil gland, eccrine sweat gland, apocrine sweat gland, and ceruminous sweat glands. location of secretory portion, so where do they secrete their stuff, how they get their stuff there through what types of ducts, way that they secrete functions, what their function is, and onset of function. So feel free to move through this table to identify all the different glands that we talked about before in a more organized table-like fashion. Our next accessory structure is nails. Now our nails are made of keratinized epidermal cell. The nail structures include this outermost portion. This is what you cut or trim, your free edge. We have a transparent nail body. This is known as the plate, so we'll draw it here. And then we have this whitish lanula. So that's this portion right here. This lanula is that white portion. The nail root is embedded, so we're going to hash out here to identify the nail root that is embedded in a fold of skin. Now we can look at a sagittal view to identify the same portions of the nail. So again, our nail root, this is what's in that fold of skin. The opunculum, which is our cuticle that you usually push back. Our lanula, this white portion, and this is and can be used to help determine health and nail health if you have a large lanula or an absent lanula. The nail bed, so we see that right here, followed by our nail body, it's the visible portion of the nail, and our free edge that we cut. Now, if we have an opunculum, we are going to have a hypunculum. Okay, so hypo means below. This is what secures the nail to the actual fingertip. And then that brings us to the nail matrix. Right, so this is part of that epidermis that's anchoring it in place, the dermis, the phalanx or finger bone. So here we have a link. If you go on your PowerPoint slide and click on that Integumentary System link, it'll bring you to Wiley, which will give you a nice little video for the overview of the anatomy of the integumentary system. It's a nice little video slideshow animation that you can watch that helps review and goes over everything that we've talked about in this lecture so far. Table 5.4 is a nice little table that shows the comparison of thin and thick skin. Its distribution, where we find it, the thickness, the stratums, the ridges, follicles, and erector pili muscle if it's prevalent or lacking, the sebaceous glands, sudoriferous glands, and sensory receptors. As we round out and complete our integument system lecture, we have to talk about wound healing. We have two types of wound healing processes which can occur. It depends on the depth of the injury. We have epidermal wound healing, which occurs following superficial wounds that affect only the epidermis. So we say, well, what happens with epidermal wound healing? So let's look at a scenario. So we make a cut, so this is a cut, and you see that we cut right to and through that stratum basal. So now what happens? That the first onset, so let's erase some of these lines. The first onset of repair is these stratum basal cells are going to have to migrate, okay? They're detached and large basal cells will migrate across the wound, which will reestablish that stratum basal into one continuous layer. Once that occurs, we're going to start undergoing rapid mitosis. So those basal cells are going to start dividing. And you can see here in this picture on the right, again, we see multiple stages of mitosis. This happens to be telophase, where those cells are giving rise to more and more cells above. So we're slowly replacing and repairing the cell layer above. And this gives us thickening of the epidermis. Now these superficial wounds typically tend not to scar as greatly as deep wounds do. And we'll cover deep wounds in our next slide. Deep wound healing, which is our second type of wound healing, occurs when an injury extends to the dermis and the subcutaneous layer. Now this is typically where we get two separate phases. One, an inflammatory phase, and second, a maturation phase. we're going to look a little more deeper into deep wound healing. We're going to look at these 4 phases that occur when we get a really, really deep cut that extends into the dermis. So the first phase is an inflammatory phase. So we build up intracellular pressure, so all the fluid in between the cells builds, which increases blood supply, increases white blood cell delivery, and also opens up lymphatics, which is our cleaning center, our sewer system of our body. So this is our wound cleaning phase. The second phase is a migratory phase. So this is scar formation. So it's migration of cells, new blood vessels are going to grow. Now, why here scar formation? So this is important. Remember, our body is in a time of panic. It's panicking. We have this open wound out into the open where bacteria can invade and can cause damage, pathology, possibly even death. So we need to seal it up as quick as possible. Now remember that deep in that dermis we have dense, irregular connective tissue set, these bundles of collagen fibers set in this crosshatch motif. Now, again, why scarring occur? Well, your body wants to repair this as quickly as possible, and it takes time to set into that crosshatch motif. So it doesn't want to set it like that. So how do we repair faster? How do we lay those collagen bundles? Like this, parallel. So by laying those collagen bundles parallel, it will increase the chance of scarring, and this is how we get scarring. The next phase is our proliferative phase. This is where our cells are going to grow, and we're going to start closing that wound and give rise to our new epithelial cells above. We're also going to form our fibers. So also fibers are going to be grown here, our collagen fibers, elastic fibers, areolar connective tissue, etc. Last is our maturation phase. This is our scab removal. This is where all those collagen fibers are going to organize, and again, it's going to organize in a parallel fashion, which will increase your scar formation. Now, as far as scab removal occurs, here we go with 2 scenarios. How many of you guys are pickers where you like to pick your scab? This is typically a bad thing. That scab is allowing for protection of the cell layers underneath it, allowing for cell growth, and allows it to take its time. If you pick that scab, your body goes into panic mode again and lays that collagen fibers parallel even faster, which will give you a higher propensity of scarring. Aging. So what happens to our integumentary system, our skin, as we age? So first and foremost, wrinkles develop. Secondly, dehydration. Our body, that uppermost layer, becomes more dehydrated, which can lead to an increase in cracking. Sweat production decreases. We get a decrease in the numbers of functional melanocytes. This results in gray hair and atypical skin pigmentation. Have a look at the skin of your grandparents or great-grandparents. You'll find these brownish to grayish to blackish, red, brown spots all over their skin. Again, this is due to aging. Next, while you're looking at your grandparents or great-grandparents' skin, take a look at their hands. Notice one thing. You can see their blood vessels a lot more distinctly. So the question is why? Well, the subcutaneous layer loses fat. And as a result, you get a decrease in skin thickness, which is why you get to see those blood vessels and bones a lot more readily. Also look at their nails. You'll see that it is more yellow, brownish, streaked or striped. That's because nails become more brittle. So again, all things that we see as a result of aging. Skin cancers. We could look at some pathologies of the integument system. So what happens when disease ensues? So how does skin cancer develop? The picture on the right is a malignant melanoma. And how do we detect this? So abnormal, uneven, roughened bumps on the skin that grow in size. What causes it? Excessive exposure of ultraviolet light, so UV light, from the sun or tanning salons. This is the most common cause of skin cancer. There are 3 major types: basal cell carcinoma, squamous cell carcinoma, and a malignant melanoma. Basal cell carcinomas are the most common form of skin cancers and the most frequently occurring form of all cancers. We can look at some numbers. Typically in the U.S. alone, we see roughly more than 4 million cases diagnosed each year. So where do they arise from? They arise from abnormal, uncontrolled, because that is our definition of cancer, uncontrolled cell growth, uncontrolled growth of the basal cell, so that basement layer of cells that we talked about when we went through this lecture. Now, these are typically curable, and they cause minimal damage because they can be treated and caught quite early. Now, squamous cell carcinomas are the second most common form of skin cancer. These are typically characterized by abnormal, uncontrolled, or accelerated growth of squamous cells. And again, the key to cancer is catching this stuff early, which means that most of these squamous cell carcinomas are curable. The last is a malignant melanoma. Now, melanomas typically occur when something goes wrong in the melanin producing cells that we talked about, those melanocytes. And again, those give rise to the color of your skins. Typically these skin cells develop in a controlled and orderly way. Now, what happens when the DNA is damaged when exposed to UV rays? So again, when you go tanning or sitting out in the sun unprotected, we damage that DNA. These cells grow out of control, and they form masses of cancerous cells. Burns. So we're going to discuss the 3 different types of burns that you can get. Now, 10,000 people a year die from burns, the most serious being third-degree burns, which involves the epidermis and the dermis. Now, these burns are typically less painful because we're destroying all of the sensory nerve fibers in these layers. The burns cannot repair themselves and require skin grafts. Now, these are also the most dangerous because infection or sepsis can occur, which is the leading cause of death. We also lose the ability to regulate temperature, and we see that dehydration and electrolyte balance ensues because, remember, water is dealing with sensible and insensible, more specifically perspiration, on a daily basis. So here's our 3 types of burns, so degree of burns. On the left, you see a first-degree burn, and again, it's called first degree because we are only burning into the first layer of the skin, the epidermis. The second degree burn, we see we're burning through 2 levels of the skin, the epidermis and the dermis. Again, this is going to be one of our most painful ones because we are getting into some of those sensory nerve fibers that are going to consistently fire for pain, and you get that chronic throbbing burn sensation that doesn't really subside until healing ensues. And then again, the least painful one, but the most dangerous one, is right here, that third degree burn. And we're going through 3 layers, the epidermis, the dermis, and the subcutaneous layer. We're getting into the blood supply where infection, now we have a hole wide open to bacteria where infection can ensue. We can get that bacteria moving into the bloodstream, which can lead to sepsis, which is typically fatal. Again, losing the ability, if it's over a large portion of our body, losing the ability to regulate temperature and water loss and sweat and waste management. So these burns can be very, very dangerous. We talk about skin grafting when we deal with repairing these areas. So again, just a little review, minor versus serious. First degree burns, only the outer layer of skin is burned, usually red with pain or swelling. Second degree burn, we burn both layers of the epidermis and dermis. We get blisters, severe pain with blotchy red marks, some pain and swelling. Minor burns usually heal with cool water on the affected area for 15 minutes, followed by sterile dressing and over-the-counter pain medication. Now, third degree burns, all layers of the skin and underlying tissue are damaged. Areas may be charred black. This is when you would need to call 911, where emergency medical help would be needed. Now, if you do suffer or encounter somebody who is suffering from third degree burns, remember to cover the area. Do not remove clothing or immerse in cold water. CPR may also be needed in most extreme situations. Scarring. Scarring is pretty important. Now, if you look at the picture on the right, you see all these lines. These are lines that surgeons and doctors have to memorize. They're called cleavage lines. Now, why they are important is because when doctors perform surgery, they typically like to cut along the cleavage lines. What this does is during healing allows for lower incidence of scarring or less chance of the ability to scar and allow for faster healing. We see more collagen fibers and we get hypertrophic or raised scars. So if you look in the picture in the middle, you see a hypertrophic or raised scar. The picture on the left are keloids. So these are outcroppings of collagen fibers. Now, how do they treat this? Usually they can remove them surgically, or they can use radiation to destroy those collagen outcrops. So let's continue with some skin cancer, UV rays of the sun, and we'll elaborate on this. So a small amount of UV radiation is good and is important for producing that vitamin D that we hinted to before, for regulating bone growth and bone health. However, in excess, it can also cause DNA damage that's going to promote those melanomas that we just talked about. So how do you protect yourself? Let's talk about SPF for a little bit, because there's a lot of issues or confusion with SPF and what to buy. So let's look at some scenarios. So first of all, how do they make and determine what SPF does or means? So typically, if you look at a normal individual that will burn in 10 minutes out in the sun, an SPF of 8 gives you 8 times that 10-minute protection. So an SPF of 8 gives you 80 minutes of high sun protection. SPF of 15 gives you 150 minutes of SPF protection, which is about 2.5 hours. An SPF of 30 is going to give you 300 minutes, which is roughly 5 hours of protection. So we're talking high sun from anywhere from 11 until 3. So again, SPF 30 is about the best that you can get. Now, when you see these 45, 60s, 100, 150s, these are marketing ploys. The amount of UVA and UVB blocked once we get really above 60 is negligible. You're talking 0.001% blockage. So what these companies do is they work off the marketing play that bigger is better, and they charge you more for an SPF of 150, when in actuality, SPF 30, SPF 45, even 60 is more than enough that you would need for even SPF 60. You're talking 600 minutes, which is 10 hours of protection, assuming you're not sweating or swimming, right? So that gives you plenty of protection for more than enough of the day. So let's look at our different UV rays. UVA penetrates deep into the dermis, affecting the connective tissue, which causes sagging skin. UVB rays are the cancer-causing rays. However, A rays do increase the effects of B rays. There are such things as non-melanomas. These don't usually produce serious illness. They are removed, but they can grow back. Those include basal cell and squamous cell carcinomas that we talked about in our previous slide. Last but not least, we can elaborate on our melanomas. Remember, they start in pigmented cells like those moles and beauty marks that you have. Survival rate is variable as long as it's detected early. If it's localized and detected early, survival rate is about 99%. That's pretty good. If it spreads via the lymphatics, survival rate drops to 14%. So again, early detection is key. We use something called the ABCs for identification of melanomas. Does it appear asymmetrical? Does it have undefined borders? And is it comprised of many colors? So is it asymmetrical? Look at the borders and again the colors. So tanning is not safe, and it increases the risk of skin cancers. Tanning salons are just as dangerous as tanning outdoors, and they may be even more because you cannot cover up. You're not putting sunblock on. So with this, our integumentary system lecture is concluded.